Valvular heart disease, the mitral valve. Case. A 45-year-old man presents to establish care. He was told many years ago that he needed antibiotics prior to dental work because there was a problem with the heart valve. He has occasional palpitations. On exam he has brisk carotid upstrokes and a hollow systolic murmur is heard best at the apex along with an S3 and a diastolic rumble. Case. What is the next best step? Do nothing, this murmur is benign. Do an exercise stress test because the patient may have had an ischemic heart disease. Do nothing, exam findings suggest mild disease. Order an echocardiogram. Refer the patient to a cardiologist for further evaluation. Case. An echocardiogram shows moderately dilated left atrium, a normal appearing left ventricle with AMF of 55%, a prolapsing posterior mitral leaflet and severe MIST. Now you should tell the patient to continue antibiotic prophylaxis prior to the dental work. Have the patient follow up with an annual echo. Refer the patient for valve surgery. Refer the patient for a defibrillator to prevent sudden death from MVP. What makes a heart murmur? High blood flow through a normal or abnormal orifice. Forward flow through a narrowed or irregular orifice. Backward flow through an incompetent valve. These murmurs are benign. Mid-systolic murmur at the left sternal border with grade 2 or less with a normal S1 and S2 and no other abnormal findings in an otherwise asymptomatic patient. Associated with normal or increased blood flow across normal valves. These murmurs need further evaluation. Diastolic murmurs. Continuous murmurs. Systolic. Loud. Early systolic. Late systolic. Hollow systolic. Strategy for the evaluation of cardiac murmurs. Bonau, Jack. 2006. When to order an echo class I class 3. Diastolic, continuous, hollow systolic, late systolic, clicks, radiation to neck or back. Symptoms of underlying cardiopulmonary disease. Grade 3 or louder mid-systolic murmurs. Class 3. Mid-systolic murmur grade 2 or less thought to be innocent. Mitral valve disease, from many structures. Mitral leaflets. Chordae. Papillary muscles. Mitral annulus. Otto. Nejm, 2001. Etiology of mitral regurgitation. Organic, primary pathology of the leaflets. Degenerative. Rheumatic. Endocarditis. Congenital. Functional, secondary to myocardial process. Ischemic. Dilated cardiomyopathy. Hypertrophic cardiomyopathy. Enriquez Serrano. Contemporary Cardiology, 2009. Mitral regurgitation, epidemiology. Prevalence, greater than 5 million. Incidence, greater than 650,000 new cases/year in the US. Most common discharge diagnosis. Most common cause of readmission less than 60 days. Cost, greater than $34.8 billion annually. Figure 25:1 Prevalence rates of heart failure by gender and age in the United States between 1988 and 1994, the Third National Health and Nutrition Examination Survey, NHANES 3. Among men, blue, the prevalence increased from 18 cases per 1,000 in those aged 45 to 54 years to 98 cases per 1,000 in those aged 75 years and older. Among women, purple, the prevalence increased from 13 cases per 1,000 in those aged 45 to 54 years to 97 cases per 1,000 in those aged 75 years and older. Data from American Heart Association, Heart Disease and Stroke Statistics, 2003 update. Dallas, American Heart Association, 2002. Rosamund. Circulation, 2008. Braunwald, 2007. Pathophysiology volume overload, greater than. LV dilation. LA dilation. Acute, rapidly increasing LA/PV pressures greater than pulmonary edema. Chronic, slow enlargement of the LA with low pressures. Left ventricular dilation and increased F followed by LV deterioration. Foster, Nejm, 2002, Hemodynamic stages of mitral regurgitation. Libby, Bromwald's heart disease. 8th ed. Natural history of severe MR. Libby, Bromwald's heart disease. 8th ed. Degenerative mitral valve disease, mitral valve prolapse. Most common organic mitral valve disease. Incidence about 2 to 3%. Usually results in mitral valve prolapse. Variable histology. Increased extracellular matrix. Thickened and redundant. Caudal elongation. Sanders, Forensic Science International, 2007. Complications: caudal rupture and flail leaflet heart failure. 12% of patients. Most common in older men. Heart failure. Sudden death. AF. Endocarditis. Most common complication, but rare, 100 cases/100,000 patient years. Higher risk with flail leaflet, mitral regurgitation, mitral valve prolapse. Foster, Nejm, 2010, echocardiogram, flail mitral leaflet. Foster, Nejm, 2010, endocarditis. Destruction of tissue by infection. About 5% of severe MR. Mitral regurgitation from connective tissue disease. Functional mitral regurgitation. Affects 15 to 20% with HF, 12% 30 days post-ME. Leaflets are normal. Coaptation is incomplete. Can also be associated with papillary muscle rupture. Marisco, Heart, Lung, and Circulation, 2008, prosthetic valve failure. Alexander, Circulation, 1995, prosthetic valve failure. Novaro, Jace, 2000, St. Jude mitral valve. Butany, Jacqueline Path, 2005, physical exam findings. Brisk carotid upstrokes, laterally displaced forceful apical impulse. Murmur, characteristics don't reliably predict severity. Similar to AS, TR and VSD. Constant intensity, holosystolic, loud blowing, apical with axillary radiation. Diminished S1, split S2, possible S3 and loud P2. Highly variable depending on structures involved. Dynamic auscultation intervention. Hypertrophic obstructive cardiomyopathy. Aortic stenosis. Mitral regurgitation. Mitral valve prolapse. Valsalva. Or standing or unchanged. Hand grip or squatting or unchanged. Supine position with legs elevated. Unchanged. Exercise. Amyl nitrite. Isoproterenol. Libby, Bromwald's heart disease. 8th ed. XR findings: prominent left atrial enlargement. Left ventricular enlargement. Pulmonary edema in acute MR. Enriquez Serrano, Contemporary Cardiology, 2009. Atrial fibrillation affects 50% of patients within 10 years. Enriquez Serrano, Contemporary Cardiology, 2009. Acute mitral regurgitation, elevated PAP and large PCWPV waves. Libby, Bromwald's heart disease. 8th ed. Variable presentations of mitral regurgitation. Enriquez Serrano, Contemporary Cardiology, 2009. Mitral regurgitation severity by echo. Structural. LA size. LV size. Mitral leaflets and apparatus. Doppler. Jet area and characteristics. Mitral inflow. Pulmonary vein flow. Quantitative. Regurgitant orifice area. Vena contracta. Right ventricle. Zogby, Jace, 2003. Medical management diuretics to maintain euvolemia. Digoxin and beta blocker for rate control. Medical therapy directed at underlying ischemia. No benefits to vasodilators. Afterload reduction and inotropic support in acute mitral regurgitation. Survival, medical management of organic MV regurgitation. Mild. Moderate. Severe. Enriquez Serrano. Contemporary Cardiology, 2009. Mitral valve prolapse repair. Foster, Nejm. 2010. Prosthetic mitral valve. Bloomfield, Hart, 2002. Survival after surgical correction by F. Libby, Bromwald's heart disease. 8th ed. Repair versus replacement repair can be accomplished in 80 to 90% advantages. Possible lower mortality rates. Possible reduced need for anticoagulation. Lower risk of endocarditis. Foster, Nejm. 2010. Possible survival benefit with mitral valve repair. Shuaiber, Ijks, 2007. Chronic severe Mr. Bonal, Jack, 2006. Percutaneous therapies. 1/3 of European patients with severe valve disease are denied surgery. Half of patients with severe symptomatic Mr. Piazza, Jack, 2009. Feldman, Jack, 2009. Mitral stenosis most commonly from rheumatic fever, 99%. 2 to 20 years until symptoms of MS. Likely worsened by recurrent RF. Also, congenital CTD, RA, mucopolysaccharidosis, mimics, tumors, infection, membranes. http://www.yale.edu/imaging/echo_entities/mitral_stenosis.html. Hemodynamics normal valve orifice 4 to 6 square centimeters. Small valve area requires higher pressure gradient. Symptoms precipitated by fast heart rate. Higher LA-LV pressure gradient. Lower cardiac output. Libby, Bromwald's heart disease. 8th ed. Hemodynamics, why symptoms develop. Increase left atrial pressure. Increase in left ventricular diastolic pressure. Pulmonary hypertension. Everything is worse with exercise. Chronic atrial changes lead to arrhythmia. Clinical findings, presentation, exam findings. Dyspnea, hemoptysis, chest pain, arrhythmia, embolic events, hoarseness. Exam findings. Accentuated S1. Opening snap at the apex with the diaphragm. A 2/0 S snap, good indicator of severity. Findings of pulmonary hypertension. Low-pitched rumbling murmur at the apex. Maneuvers that increase mitral flow increase murmur and decrease A2/0 S time. Echo determinants of mitral stenosis severity. Baumgartner, Jace, 2009. Echo determinants of mitral stenosis severity. Mild. Moderate. Severe. Valve area, SM2. Greater than 1.5. 1.0 to 1.5. Less than 1.0. Mean gradient, Hg. Less than 5. 5 to 10. Greater than 10. PAP, Hg. Less than 30. 30 to 50. Greater than 50. Mitral valvuloplasty score. Baumgartner, Jace, 2009. Natural history of 159 patients with unoperated mitral valve disease. Expected survival. Mitral stenosis. Mitral regurgitation. Libby, Bromwald's heart disease. 8th ed. Management approach to mitral stenosis. Nobuyoshi. Circulation, 2009. Percutaneous valvuloplasty. Nobuyoshi. Circulation, 2009. Long-term outcome for percutaneous valvuloplasty. Libby. Bromwald's heart disease. 8th ed.